presentation, which is with Dr. Bree-Ann Flay. Dr. Bree-Ann Flay is a clinical psychologist with Reflect to Connect Psychology. She focuses on infant and early childhood mental health, child welfare, and diagnostic assessment. She has also been on the ground with us from day one with Safe Babies Court, helping to get this implemented here in Jackson County, and is a huge asset to that team. So Dr. Slay, I'll let you introduce yourself a little bit and take over.
Awesome. Okay. Looks like slides are working. Everything's working the way it's supposed to. So I will go ahead and move us to just some of who I am and my background. I'm glad that you all already did your land acknowledgement so that I don't have to read a super long one on my end. But my name is Dr. Slay. I am a clinical psychologist. I specialize in infant early childhood, but do a lot of assessment and supervision and lots of things. A couple of pieces as far as things that are important to me and have kind of shaped and informed who I am today and the work that I do today. So I am not from Kansas City. And so I am an outsider coming into this system and learning a lot about Jackson County in the few years that I've been living here. But I'm originally from Detroit, Michigan. I went to grad school at the University of Denver, where I received my master's in forensic psychology and then got my doctorate in clinical psychology. And so my background is a lot of, I've been a probation officer, I've worked in family court in Denver, jails, prisons, competency restoration, but my heart is in foster care. Did my internship at LSU in New Orleans and worked on the Safe Babies Court team down there. Haven't got to learn a ton and do some great work. Again, learning a lot more about infant mental health and particularly the Safe Babies approach and doing that in the particular cultural and political and all the other areas of what informs what the culture is like in New Orleans. And so knowing that that looks a little bit different up here in Kansas City. I'm on the board for Missouri Infant Mental Health Association, and it has a big part of my heart and a lot of what I do. And then just some acknowledgements of some mentors and people who've really kind of paved the way and got me into where I'm at now. And so one of the things that I wanted to mention too was that you might notice some similarities across some of the presentations this morning, which I think is just reflective of such a collaborative efforts that we've all invested. A lot of us have worked with many similar organizations and backgrounds and data. I've had the great opportunities to do trainings and presentations with Safe Babies Court before, working with 0 to 3 and some folks, Darnie Chabelle being one of them. And so I won't go in too much detail with some of the areas that have already been addressed, but I think it'll help me to spend a lot more time on some of the areas that I really want to for the presentation because we can jump over some pieces. Okay. So a couple of objectives for plan for today is really just kind of increasing the knowledge of CPP, the introduction and the graphics that Patty and Holly used in their presentation this morning. I think were really great to overview, and then we'll just be digging deeper into some of those areas. Understanding the long-term impact of early trauma, which again, we had some of those seeds planted in some of our earlier presentations, but then also looking at infant mental health and what that looks like and the importance of that in successful reunification. So what is CPP? CPP is an evidence-based model. It is a dyadic treatment model. It's used to heal young children and their families from trauma. It's appropriate for children age 0 to 5. It has been used for children outside of that age range, but just know that the research isn't always in that age range. And so then that evidence-based categorical classification doesn't always apply if you're going outside of that age range, but there has been some work shown that it has been helpful for older children. But children age 0 to 5 who have experienced traumatic stress, children who have behavior problems, who are experiencing ruptures in attachment, or who have other mental health problems. And so this quote will kind of anchor and I think really bring us through the presentation, because I think the best way to understand CPP is by breaking this down. So CPP is designed to repair the behavioral and mental health problems of infants, toddlers, and preschoolers whose most intimate relationships are disrupted by experiences of maltreatment, violence, and other forms of trauma that shatter the child's trust and safety and attachment or of attachment. And so the first part of this sentence that I think is important to really break down is behavioral and mental health problems of infants, toddlers, and preschoolers. And we'll go through some of this pretty quickly because I think it's been really well addressed through the morning. But we need to acknowledge and address the fact that babies do have mental health problems. We do see experiences of expressions of mental health issues in the 0 to 5 age range. There is a particular manual, the DC 0 to 5, that was developed by 0 to 3 that gives us, I think, a more developmentally appropriate view and breakdown of what these different diagnoses look like for this age range. We know the DSM, and that's standard, but some of that always isn't appropriate or really takes into context the developmental pieces and the developmental context of this age. It's important for us to acknowledge and to see the problems that infants, young children, and babies have. As attorneys, CASAs, GALs, you all are in a really special position to really see and identify and document these behaviors. As advocates for children, it's important for us to see them, but also to help everyone else on our team, if we're thinking about the Safe Babies approach, to see them. And so letting the parent aides, the judges, the caseworkers, so that we're all kind of taking the same lens and identifying some of the same things. It's a lot easier, I think, for us to see some of the externalizing behaviors, tantrums, aggression, screaming, crying, all of that outside stuff, self-harm when a child is, banging their head on the walls or floors or scratching themselves. It can be, because it's not as at our forefront, I think it can be harder for us to see those quieter symptoms. When I hear people tell me that, they have a baby who never cries, who's super chill, that's always concerning to me. Particularly in this context of trauma and working with young children who've experienced trauma. Babies who aren't sleeping, babies who are very lethargic, social withdrawal, reduced expression of positive emotions, lack of interest, not playing as much as we think they would be, a general sense of detachment, as well as developmental regression, losing their skills. They used to be potty trained and now they're not. We're seeing eating problems. We're seeing language loss. A child who had language and is now doing baby talk. Those are some of those symptoms that are important for us to look at too when we're thinking about trauma in babies and infant mental health problems. Some of the areas that have already been addressed, I think Patty and Holly talked about this pretty extensively this morning, but knowing that we can help to nurture and support healthy development. And that happens through consistent, small instances of discomfort and stress and a consistent response to that. So a baby and a parent are working together as collaborative partners to try to resolve issues. When a baby cries, the parent is trying to figure out, are they hungry? Do they need a diaper change? Are they sick? Are they cold? Are they too hot? And doing that work together in that consistent cry, solve the problem, cry, solve the problem, builds trust, builds relationship, and builds attachment. And when babies are able to consistently experience that regulation after a period of dysregulation, they learn to trust, they learn that they can get help when they need it, and they learn that ideally the person that does help them is their parent. So the next part of this sentence is behavioral mental health problems in infants, toddlers, and preschoolers whose intimate relationships are disrupted by experiences of maltreatment, violence, and other forms of trauma. And so we all know that children in this age range experience trauma. We talked about ACEs pretty extensively, and so we won't go into that too deeply. I will just say that it's also important for us to really think about separation when we're talking about trauma. Separation from a caregiver, even if that caregiver was harmful, is traumatic to a child. And each subsequent move in separation, when a child is moving from foster home to foster home, relative caregiver to relative caregiver, each of those experiences can be dysregulating and traumatic for the child. And so trying to mitigate that as much as is possible for all of us. When experiences happen and caregivers are not able to keep their children safe, then what happens is the state steps in and we have the support of the foster care system. And then don't need to preach to the choir here. We're all very familiar with the need. 2020, I'm sure it's pretty different now, but at that time, almost every 7 minutes, a child was being placed into the foster care system. The data that Judy shared earlier about young children being the overrepresented in the foster care system, but also more specifically to Missouri. And so this data about Missouri in 2021, 20% of children entering foster care are less than the age of 1 to 5, 30%. Again, putting those together, we get close to that 49, 50% that Judy was talking about. And then, of course, it's no surprise that children who are in foster care, and particularly the research that was done through some folks in Safe Babies Court team and one of my supervisors, Dr. Joy Osofsky, was looking at the rates of ACEs experienced by children who are in the Safe Babies Court team programs. And so what we see is that these are children who are in Safe Babies, it's typically 0 to 3, who have had 4 or more ACEs already, which is that's about 60%, 59% of the children in the Safe Babies Court team, which puts them at a really high risk for more significant health risks later, like we know with the ACE studies and the research that was done through Kaiser. And it's important for us to address this trauma because it does have a significant impact on their development. And of course, as you can see, the disparities, they're like several times, 3 times the general population of experiences of ACEs. So I won't go too much into development, but we need to address trauma because we know trauma affects development. We've got this slide that we saw earlier. There's those peaks in brain development and what's happening in those first 2 years. Patty and Holly already talked about differences in brain development. And so not only is that prefrontal cortex having less development, but we're also seeing other areas of the brain that are less developed. This research was done looking at brain scans of children in Romanian orphanages. And so we're seeing generally a lack of activity in these areas in comparison to those who have not had trauma. And then, of course, differences in brain size. Children who have experienced extreme neglect. Some of the research done by Dr. Bruce Perry is also showing that their brains are different in size. So not just the development, but the growth. And of course, as we talked about, what we can see. So impaired brain development, we see increased rates of learning disabilities, difficulty in our control of emotions and impulses, that stress response that they were talking about earlier and kind of going into the dysregulation of cortisol, increased arousal of the sympathetic nervous system. We also see general immune differences. These are kids who get sick a lot more, and general alterations in physical growth. One of the things that I've noticed, and I'm sure you all have probably seen too, is when I have kids that are entering the foster care system, they're often very small. They're often not developing at the rates that we would expect them to be. But when they're experiencing that consistent, good enough, positive care, good relationship, I have several kids that I worked with in Safe Babies in New Orleans who just shot up and grew and were going through clothes so quickly because they were getting the support that they needed. And so their brains were able to focus on growth and not on survival. And then, of course, we know that ACEs have a cross-generational impact. If we're not addressing the trauma, if we're not getting in there and making the changes and providing the support, then that has a lasting impact into adolescence and into adulthood, where we then get adults who are having pretty severe difficulties, who are experiencing continued trauma and who can find themselves into pretty difficult situations. I'm sure that you all probably had some kids or have worked with folks who were kids, and years later, you're seeing them again on the other side of the coin, and now they're adults that you're serving. So jumping into this last part of the sentence here, that these experiences shatter the child's trust and their safety in attachments. And so I want to spend some time on attachment and kind of digging into each of those areas, because attachment science is one of the kind of main theoretical orientations and underpinnings of the work that we're doing in infant early childhood, especially in the work that we're doing in CTP. So, what is attachment? Um, One of the things that I always like to kind of dispel a myth is that there are not children who are not attached. Every child has an attachment to their caregiver. It's a matter of if that is a secure attachment or if it is an insecure attachment. And insecure attachments can fall into subcategories. But attachment essentially is the way that a child has adapted to get what they need from their caregiver, based on the caregiver's consistent or consistently inconsistent responses. And it's, again, not something that you have or don't have. When we think about secure attachments, right, these are children who trust that their parents are consistently available. When the child is frightened about something, when they're unsure about something, they can look to their caregiver for reassurance. And if that caregiver is calm, if that caregiver isn't frightened, then that child may feel more secure in that situation or in a scary situation. The child may move closer to the parent to touch base, but then they'll return to whatever it was they were doing, because they feel secure, they feel safe to go out and explore their environment. If we're looking at our anxious ambivalent attachment, this is one of those subcategories of insecure attachment. In this category, these are children who have not been able to count on their parents to respond consistently. And I also want to say that, right, when we're talking about secure attachment and parents being consistent responders, that doesn't mean that parents don't have bad days, right? I'm sure we've all had moments where you got annoyed or you snapped at your kid, or maybe you weren't the most empathetic. But in general, right, the majority of the time, they know that they can expect a certain response from you. On the anxious ambivalent side, this is a child who isn't quite sure what to expect, because they can't count on their caregiver to respond consistently. Sometimes the parent's really nurturing and supportive and empathetic, other times they're not. And so these children can use two coping strategies interchangeably, where they can be really clingy, and they can also have this kind of fake independence, to, again, try to figure out, how am I going to get what I need depending on which side of you I'm going to have. Because at the end of the day, right, babies can't survive on their own. We are a very useless species. As babies and children, we need adults to survive. And so babies are going to figure out what they need to do to get what they need from that caregiver. And if that means I need to cling on to you and I need to stay next to you so that I know that I can be fed and secure and cared for, then I'll do that. If that means that I need to pretend that I don't need anything from you and I got this and I can figure it out on my own and be independent, then I'll do that. And depending on which side of you I'm going to get is how I'm going to respond. In the anxious avoidant attachment, this is a child who has learned that their caregiver is not there, that they are not able to meet their needs, that they are not able to provide, or to support them or to help them when they need it. And this can be literally the caregiver is not there, but this can also mean that they are emotionally not available. Like when we have parents who are experiencing severe depression and they're not able to attend to, identify, and meet the child's emotional needs or physical needs. And so these are caregivers who, again, kind of on that side of independence, behave like they don't need their parents' attention. They're hyper independent. They make themselves not have needs, and they teach themselves that their own needs for comfort, support, love, protection are not important and certainly can't be met. So then moving over to our disorganized attachment, and I won't go too deep into this because disorganized is one of those weird categories where you're disorganized for a little bit and then you funnel yourself into ambivalent or avoidant. But this is a common attachment classification associated with children who have been physically abused, and it is known as one of the most difficult to treat. Doesn't mean we can't treat it, just means it takes more time. And that these are children who don't have a strategy for dealing with their parents' inconsistency or failure to protect or nurture. And so they can act in odd ways or in confusing ways because they don't know what to do and they don't know how to get their needs met. All of that to say, attachment relationships are person specific. A child can have an ambivalent attachment to one caregiver and a secure attachment to another caregiver. It's about the dyad. And this is important because that means that we can capitalize on secure relationships to promote development. But again, knowing that attachment is really only identified with a primary caregiver, and knowing that in multi-generational households or in different cultures, there can be multiple primary caregivers. Let's see. So we know about ACEs. We know that trauma has a cross-generational impact. So it's not too far for us to kind of take this leap and look at adults, parents who are involved in Safe Babies, parents who are involved in the foster care system. And so just like the children who have high rates of 4 or more ACEs, the adults that participate in Safe Babies Court Team also tend to have high rates of 4 or more ACEs. This lets us know that the parents are suffering too. And these are parents who have hurt or failed to protect their children. And that's why we're kind of in this situation. But they also probably haven't had that experience. They probably haven't grown up in situations where they were protected from harm, where their emotional needs were supported. And so thinking about that and how we are supporting the children that are getting services, it's important for us to also remember that we have parents who are experiencing mood symptoms, traumatic stress. This may have led to some of those adulthood cross-generational symptoms like substance use or getting into relationships that then, find themselves to be really unhealthy, poverty, all of the other things. And these are parents who we can work with to foster resilience, to break cycles of intergenerational trauma that are often, unfortunately, created and supported by systemic inequalities. One of the biggest things, if we take anything away from today, is just that reminder that these adults were children too. And if we can kind of find that child in them and support and nurture the child in them, then we can build those skills for them to support and nurture their children. So often in court systems, and I've been, haven't been all around the world, but I've been able to work in foster care in Michigan, in Denver, and in New Orleans, and now here. One of the things that I've noticed is that it's very common for services to be mandated individually. And it's not enough for us to just treat the child or to just do individual therapy for the parent, because we need to do the work on supporting relationship. And while it may be, and probably is still helpful for them to have additional services like domestic violence support, batters intervention, substance abuse, or even giving them, parenting education, parenting classes. What we know and what the research has shown us is that services on their own have not necessarily prevented kids from coming back into the system. We often have this revolving door of kids getting reunified and then they're right back. And so what we need to do is really think about and focus on the relationship, because we can't treat families in silos and in isolation. One of the things that we're often tasked with doing and representing, and I know particularly for you all on the legal side, is representing what is the best interest of the child. And what we know from the research is that the best interest of the child is to be in a healthy, nurturing, and protective relationship with their caregiver. CPP helps to do that. In CPP, because it is a relationship-based, trauma-informed, dyadic treatment model, we help to facilitate that long-lasting change. In CPP, the relationship is the client, not the parent, not the child, but the relationship. And we can't understand the relationship if we're only looking at one side. And so I think it's really our collective responsibility to intentionally promote working to treat both the child and the parent's needs in a direct effort to break the cycle of generational trauma and child welfare involvement that we see in many of our families. And by supporting the parents, we are supporting a healthy way of living, a supportive way of living and parenting that makes for a healthier home for everyone involved. By treating the child concurrently, we're interrupting that cycle so that that child doesn't go on to continue to experience suffering from the frightening experiences they've had, or to potentially continue to inflict harm on themselves or others. And while individual treatment can do great work, it can't just be about the provider doing that work to support for the child, because providers go away, right? We do our job and then we move on. The caregivers are the ones who stay. So it's better for us to really strengthen and support the caregiver's capacity to do that work with and for their child. In the Safe Babies Court Team approach, reunification is one of the most common types of permanency, with a median time of 9 to 10 months, which is about 6 to 8 months sooner than children in the comparison groups. And there's a lot of different treatment models that are used in a variety of Safe Babies Court systems, but CPP is kind of the big one and most often recommended. So, what are some of the premises of CPP? In general, CPP happens weekly sessions. It involves consistent caregiver involvement. And when we say caregiver, we're talking about not only biological parents, but we're also talking about the foster parents, the relative kinship placement. Any caregiver who is supporting that child would benefit from and can get these services. The sessions can last about 5 to 8 months, but for some families, they last longer. There are some families who are in CPP for a year plus. And one of the big premises and kind of our guiding lights in CPP, and one of the things that I know Patty had mentioned earlier, is that we know that caregivers, parents and caregivers are the most important people in children's lives. And so this makes them essential figures in the therapeutic process. And it is their job to ensure, the caregiver's job to ensure that the child understands that they were not the cause of what happened, that they are loved, and that the parent is sorry for what happened and wants to protect them. And so, again, kind of going back into that, supporting the parents to be the change makers, it's really difficult. It can be difficult for parents to do something and to act in ways that they haven't received themselves. And so it's helpful for us to maybe try to identify and find those experiences in their history, but also for us to model and support, be the way that we want our caregivers to be for their children. And of course, you know, as attorneys, as therapists, as, you know, whatever roles we're playing, we're not their parents, but we can also still provide them reparative experiences by being kind, being empathetic, acknowledging their growth, and taking that stance of knowing that we're here to help and that we see the good in them. Let's see. Okay, trying to be mindful of my time. So the goals in CPP. Again, this work is necessary for the parent and the child because their trauma and its impact on the caregiving environment is often what led to placement in care in the first place. And so if we're only doing individual therapy, we're not addressing that. And so our goals really target those areas that are needed. We're looking at development and coping, and we want children to be able to return to normal development and have more adaptive coping skills, to engage with their present activities and their future goals. We want to identify and address the past, but we don't want to get stuck in it. We also want caregivers and children to be able to respond realistically to threat. People who've experienced a lot of trauma, their safety radars tend to be a little bit out of whack, where they may over respond to situations that aren't really unsafe, or they're under responding to situations that are really unsafe. And we want to balance that out. We want to reestablish trust in relationships, trust in their bodily sensations, so that they can listen to and hear and understand what their body is going through and feel some control over that, as well as managing trauma. One of the things that's important to think about, and to consider or keep in mind, is that depending on the extent of the trauma, depending on the parent's history, and a lot of the details of the situation, it can be common and possible for a parent and a child to trigger each other. In that, if we don't see that in action in treatment, and by thoroughly understanding each person's history, we can miss opportunities to address it. So again, another reason why that dyadic therapy is important, because I can address the child's trauma in a separate session, I can address the parent session or the parent's trauma in a separate session, but I can't see how it impacts each other if we're not doing the work together. And when we're working to reunify a child and a parent to return home, if we're not providing these tools for understanding, these new ways of understanding each other, fixing the relationship, then these families can find themselves winding back up into care. So we are supporting the healthy development of CPP long after CPP is done. A lot of the work that we're doing is, again, growth promoting for that child-parent relationship and relieving the negative effects of trauma by helping children to understand that these experiences can be alleviated through help, that adults are there to help them, that the child didn't make the bad thing happen and shouldn't internalize that self-blame as they tend to do because of development and egocentrism. Strong negative feelings can be processed and transformed instead of reenacted through harmful behavior. And that while there have been negative experiences, life also contains really positive experiences of pleasure, mastery, and hope. And we know it works because research says so. There's a lot of research that's been done to support the effectiveness of CPP. And just to bring some special attention to one of their most recent studies that came out, I think, August 24th of this past month. But one of the more recent studies has found that CPP is associated with lowering the pediatric epigenetic age acceleration. And so, again, just more research supporting the effectiveness of the CPP model. So how do we do it? What does this entail? CPP has 6 main intervention modalities, and I'll go through each one, but we are encouraging growth through play, physical interaction, communication. The language of children is play. While some kids are very verbal and speak and can talk about things, a lot of what we see and a lot of what they're trying to tell us comes out through their play interactions. And we can encourage growth and we can create change through doing those play-based interactions. We provide informal, reflective developmental guidance and advice. So CPP is a really reflective model. There may be moments where we're providing psychoeducation, but we're not in the business of sitting down and telling a parent, you need to do this, this, and that. We know that people are more likely to create change and to do something different if they can come up with the solution themselves, and if we can help to build that reflective capacity to solve their own problems. We also demonstrate suitable protective behaviors. And so while we are reflective and we're not super directive, if there's something unsafe happening, right, we do address it in that moment, and support the caregivers in being the one to be the addressers of unsafe behaviors. Explaining emotions and behaviors and how those are connected to the behaviors that are happening at present. offering emotional support and delivering crisis intervention, managing cases, and offering practical help with daily challenges, because we know it's really difficult to do the deep trauma, psychoanalytic work if you don't have lights on in your home. So it's important for us to address the everyday necessities as well: childcare, education, employment, housing. And being on a team is super helpful for that, because we have caseworkers and we have our CASAs and our GALs and our TIES program and all of these organizations that can help to meet those needs. One of their big things that they say in CPP is to do not yet target for treatment what you do not yet understand. And this is a quote that I keep in my head, try to keep in my head all the time when working with our families. We often, in CPP, we talk about the triangle, and what's often seen in kind of first line of trying to address is behavior. But once we start throwing in interventions and trying to do all of these things to address behavior, it's not going to really do much, and it's not super helpful if we don't understand how we got there. And so they talk about that bridge of experience and behavior. We need to understand the experience to connect that to the behavior. And then we use CPP, the treatment, to discuss how that's going to help. And so when you get reports, court reports from your CPP clinicians, also keeping that in mind, that we're setting that same framework to understand the background, to understand how we got here, and how what's happening now is an expression of that past history. And all of that within the context of protective factors. And so one of the things that we do in CPP, when we get into the core intervention phrase, is we do the triangle with children, and we come up with that together with the caregiver to help children understand, when you were little, this thing happened, and now this is the behavior we see, and therapy is a space where we can help make those things better. And so CPP is in 3 phases. We have the assessment engagement phase, core intervention, and then recapitulation and termination. And so we can't figure out that history, and we can't get to that left side of the triangle until we get to know the family and we know what's happening. Keeping that in mind, right, it takes a while to build relationship with people, and particularly to build relationship with folks who don't want to be there, because they're experiencing the trauma of having their children removed from them. And maybe on some level they're like, yeah, I want to be here and I want to get the help, but they really don't like the circumstances that have led to them being in our office, whether it's court ordered or not. The best practice is that it wouldn't be court ordered. But it takes time to build that relationship. And people who've experienced a lot of trauma can be, pretty closed off and keep things close to the chest because they're trying to protect themselves. But keeping in mind, if we think about those premises of CPP, and at the bottom there, actually, I'll go back, that piece of speaking the unspeakable, here we go. We have to address it. We have to talk about what's happening. But we're not necessarily going to jump into that on day 1 in session and say, tell me all about your trauma. But we do get a very thorough history, and this takes time. We get background information, developmental history, trauma history, and symptoms for the caregiver and for the child. Depression screenings, we do attachment assessments, and then we also look at the angels and ghosts in the nursery for that caregiver. And this assessment happens not only with the biological parent or the parent who's been identified as the caregiver for the purposes of the case, but also with their foster parents or their biological parents, because we know, or with their kinship placements, because we know that young children who have experienced a lot of trauma, who can have some big behaviors, can really trigger and kind of get into a soft spot for adults who are caring for them, adults that are supporting them. So it's important for us to support all of the adults that are supporting those children. And so the foster parents, it really helps a lot if they're involved in services too. We set the frame that children's behaviors are best understood as responses to things that have happened to them, and that it's essential for the caregiver to be able to entertain the possible connection between what has happened and how the child is behaving. And so it's essential not only to know about the experiences, but to be comfortable discussing them, because in core intervention, that's when we get into that work. And then just a brief kind of overview on the ghosts and angels in the nursery. There's like a whole training you can do on that. And like there's a ton of research and it's a whole thing. But condensed version is we understand that ghosts in the nursery are, for caregivers, the forgotten feelings that are expressed through their perceptions and behaviors and attitudes that they have towards their child. And so this could be trauma that they've experienced, but it could also be experiences of feeling unheard, unloved, ununderstood, or misunderstood by their caregivers, and that internalizing those experiences can come out in the relationship that they have with their children. And it's important for us to understand that so that we can see when that may be happening and support parents in building their reflective functioning and practice on connecting those dots. But we also look at angels in the nursery because we want caregivers to remember, think about, and internalize those positive experiences that they had as children where they did feel understood and they did feel accepted and they did feel loved, so that we can get to a point in therapy where something's happening and maybe they don't know how to respond or they don't know what to do. And I might say, you know, what would Grandma Betty do if that was that person that they felt loved and supported by? How can we internalize that person so that you can use that experience to have more positive experiences with your children moving forward? In order for us to do the work that we need to do in CPP, we have to take a stance that children or that caregivers and parents do not want to hurt their children. We have to understand their history and their pain, and that those patterns may be reenacted in the relationship with their child, but that it is not their intention to do so. Because if we don't believe it, and if we don't take the stance that this family can get support and can be helped, the parents aren't going to believe it. And this is, you know, really tough work to do. It's important for clinicians to take a reflective stance and to have support to keep us from getting burnt out, jaded, losing hope. There's this quote that they have in the CPP book that I find really fascinating, so I'll kind of go through it quickly. But this is by John Bowlby, who says that children not infrequently observe scenes that parents would prefer they did not observe. They form impressions that parents would prefer they did not form, and they have experiences that parents would like to believe they have not had. Evidence shows that many of these children, aware of how their parents feel, proceed then to conform to their parents' wishes by excluding from further processing such information as they already have, and that having done so, they cease consciously to be aware that they've ever observed such scenes, formed such impressions, or had such experiences. Here, I believe, is a source of cognitive disturbance as common as it is neglected. So what he essentially is posing is that children have an understanding that their caregivers don't want them to know certain things, that their caregivers really would rather that they didn't see certain things that they did see. And so they find themselves conforming to that belief and kind of changing their experience to not remember the things that they know they saw, to not believe the things that they know they experienced. And this is how we get to adulthood experiences of dissociation, depersonalization, amnesia, difficulty with assessing reality, because they've learned from such a young age that I can't trust what I saw. And so that speaking the unspeakable piece is really important. And it's essential for the clinicians to have all of the information and to have all of the data, because sometimes parents are not ready to, or maybe not willing to, acknowledge the trauma that the child has experienced. And this can be a really difficult position for them to be in legally, because the advice that they're often getting from their counsel is to not say things that may be incriminating and to not admit things that maybe they have done. But this becomes an issue in treatment, because then they're denying their child's experience and they're invalidating that child's experience, which can cause more emotional harm. And so it's really important for us to be able to have that protected space in therapy where we can do that work. So, core intervention. Again, this is weekly meetings. We are helping. This is when we are bringing the child and the caregiver together. The assessment phase is often caregiver alone, one-on-one sessions, and then we bring them in together for core intervention. And we are helping children understand who we are and what we do, why we're meeting and what we're doing in therapy. And then, of course, we also meet with other caregivers. It's important for us to help caregivers and parents to understand what their child has been through and how what their child has been through may affect their development and relationships, to help them understand ways to keep them or to help them feel safe, as well as to find ways to strengthen the relationship as a way of helping the child heal. We live in a lot of generations and cultures where you don't talk about bad things and we pretend they didn't happen. And then kids learn, I just have to figure this out all by myself. And CPP is unlearning some of those things. And we also help parents and children to understand each other, to be able to talk about the experiences, to be able to respond to difficult feelings, and to create a new family story that leads to healing. So then in phase 3, which is our recapitulation termination phase, this is wrap up and future planning. We know that ending sessions isn't just a one-time, right? It isn't a, here's our graduation appointment and goodbye. It's a phase. It is it takes multiple sessions. And that's important because we want to make sure that the dyad feels supported and ready to be out there on their own and away, from us. But it's also important because these are children who, and caregivers, honestly, too, who may not have had good experiences of goodbyes, who may have had multiple experiences of people showing up and disappearing, and that's it. All right, I was here and now I'm at this other place, and that's it. And it's important for us to show and demonstrate that we can have positive goodbyes and that there are people that are in your life for a time and they're there and they're helpful, and we end that on a good note and then we keep moving. So with all of that in mind, and knowing that children have experienced multiple instances of trauma or frightening instances, caregivers who have experienced trauma and frightening experiences, who have gotten to, arguably one of the worst places in their life, being involved in the foster care system, we can do that repair. And we know that it only takes one. All it takes is one healthy, secure primary relationship to mitigate the effects of trauma for a child. And through CPP, we are facilitating that. We're facilitating that healing, which has a long-lasting impact for families. And while it does only take one secure relationship, we're doing the work to try to get this family as many positive, secure relationships as possible. And this is also why it's important for relative caregivers, foster caregivers, to be involved in treatment, because if reunification is not possible or isn't able to happen, then at least this process is facilitated in another relationship. Best case scenario is the child is experiencing healing relationships all around, but if they aren't able to get that in the relationship that we're hoping to reunify, then we can still facilitate healing and long-lasting change in other caregiving relationships. So I think that gives me just a couple minutes left for questions. I apologize if I talk too fast, but yeah, that's CPP. There's a website, childparentpsychotherapy.com. The developers are amazing people. There's a ton of really great videos on YouTube on their CPP channel if you want to kind of learn more and kind of see more about what that looks like, as well as how other Safe Babies Court teams are using the CPP model.
Awesome. Thank you so much, Dr. Slay. I don't see any questions in the chat right now. So if someone has one, go ahead and load it in there. But what fantastic information. I really appreciate your comments about it only taking one relationship to help, and the focus on your client being the relationship between the parent and the child is really eye-opening. So,
and sometimes, sometimes that one relationship is with us and the caregiver. if they can have a positive relationship with you as their attorney, with their caseworker, with us as a clinician, hopefully they internalize that experience, and that's helpful for them going forward too.
Wow, that is so wonderful to hear. I don't see any questions being loaded. So with that, we will go ahead and break for lunch.